Hello everyone, you're watching another episode of In Person with me, Lakshmi Baker, and today I have with me a personality that he's really interesting to interview. I can't wait. I think I've been waiting almost 2 years to interview a personality like this. He is none other than Mr. Dr. Stephen Jambunathan. He is one of the most renowned but low-profile psychiatrists in Malaysia, so I'm really happy to have gotten this opportunity to interview you today. I've got 1 million burning questions because the human brain fascinates me. Half an hour is not enough. I need 1 hour to ask you all these questions after I did my research about you. So without further ado, let's go straight to the bullseye. My first question for you, Doc, is I read about EMDR, eye movement desensitization and reprocessing. I'm wondering if I'm going to ask you about this. Are you going to start studying me? And is this a kind of therapy? And can you explain how this therapy helps with what sort of mental disorders?
Well, EMDR basically stands for eye movement desensitization and reprocessing. Now, it was initially created for post-traumatic stress disorder, for people who have experiences that make them, where they feel that they almost died. And it stays with them. It's locked in their memory. It's memory loops that go on and on. But now we've begun to redefine this experience of PTSD as any form of memory that sticks in, whether it's a breakup or whether it's a huge financial blow or whether it's a very bad confrontation with a friend. As long as it sticks in your head and it goes round and round.
But you said almost died. What has breaking up with someone got to with almost died? That means they tried to commit suicide or something like that?
That's the redefining. Almost died. PTSD initially was like a very bad car accident. And God, I thought I was going to die. And you go back and you have flashbacks and agitation and withdrawal. So EMDR for PTSD, but now EMDR is for anything that involves locked-in memories or emotional repercussions as a result of some experience.
Understood. So for those of you who can't follow what EMDR is, actually eye movement desensitization reprocessing. Can you do a short demo for me? Like what this is a process that does not involve medicines. It's a non what you call it pharmacological. So it doesn't involve. So how do you heal a patient using this method?
Firstly, it is not a form of hypnosis. It is very circulatory. It deals with the circuits in the brain, and by movement of the eyes, which I will try on you in a while, you sort of detach the hurtful feelings to that of the memories. Now we have a sad memory and we have a very hurtful feeling. So you remember stuff, but we take away the traumatic attachment to it. Interesting.
And is this a one-off process which helps heal the patient, or you have to do it a few times in order for them to forget that traumatizing incident?
Sometimes it takes just one session of an hour. Sometimes it takes about 5 sessions of 5 hours. It depends on the individual. And what we use to monitor the progress is their recollection of certain memories, the degree of the emotions, and their bodily sensations. And
so do you want to
just to show you how it works. Now, what we would say is be calm, relax. Don't think of anything. Just follow my fingers. And it goes like this. Very good. Stay with my fingers. Don't move your head. Now take a deep breath and relax.
That was a bit...
What comes to you now?
I feel a bit nauseous. But maybe I'm not in a frame of mind where I'm trying to heal anything at the moment, though all of us do. But yeah, just a physical sensation of feeling a bit dizzy.
Now that is one of the things we monitor. But people who come in with feelings or emotions or thoughts
that they're ready to pour out.
Yeah. Will gradually change. The pictures will change in their mind after each session.
Right.
The anxiety levels will go down. One particular patient who had lots of images and lots of sad thoughts left after 5 sessions saying, "Doctor, I don't feel anything bad now."
Just by doing that and not talking about the problem.
Yeah.
Just by that movement.
But by monitoring stuff in between, there is a process to it.
So basically, you begin your session with that, and then they start pouring out, and then the counseling happens, and then
we begin our session with discussion, preparation, and then the eye movement.
Right. Okay. So great. We know what that is all about. Maybe one day we'll have the privilege to actually record an actual session. Didn't work much with me today because I didn't come in to pour out. Okay,
it's very exciting.
Yeah, it is. It is. Okay, we haven't talked about psychodynamic psychotherapy and cognitive behavioral therapy. That's also another non-pharmacological approach. I've seen a lot of this repetition in your resume about CBT, about cognitive behavioral therapy. Can you explain what it's for?
Well, psychotherapy itself is therapy of talk.
Okay.
Without using medicines or with using medicines.
Can you heal someone who has depression and all these mental disorders by just talking to them?
Yes.
But does it depend on the level of depression? If like someone is like manic depressive, then you definitely need medication, or can you cure someone who's severely depressed by just talking to them?
You are right and not too right.
Okay.
If you are severely depressed, it's not worth taking the risk all the time, keeping in mind suicide by just talking. One would benefit with 2 hands than with 1 hand.
Yeah.
But yes, mild depression, mild anxiety, for that matter, obsessive compulsive disorder, can be treated with either psychodynamic, that would mean dealing with the past, or cognitive behavioral therapy, which would mean changing your thinking and behavior here and now and for the future.
So that's what it means, simply CBT.
Simply, yes.
Okay, now we're going to take a short commercial break. Like I said, I'm asking so many questions. We've got more questions to ask. Right after this, we've watched a lot of movies that depict schizophrenia and schizophrenics, and it's very glamorized and commercialized. But we want to find out from an experienced psychiatrist like Dr. Stephen, what do they really hear, and what is it really like for a schizophrenic right after this commercial break? Hello, you're still watching In Person with me, Lakshmi Baker, and we're still on In Person. And today, it's all about mental disorder. And one of the main things that I want to bring forward to you guys out there is that there's still a stigma when it comes to coming forward when you have or feel that you or your family members or someone you know has got a mental disorder. So this session that I'm going to expose you to in a couple of minutes is about coming forward and not feeling shy or uneasy about seeing a therapist and how beneficial it could be. So I hope you pay attention.
Hi, Angie.
Hi, doctor.
How are you today?
I'm fine.
Thanks for coming in for the interview.
No
Although
problem.
it's going to be very brief for educational purposes.
Yes.
I would like you to tell us, or at least tell me, what brought you first here to the Center for Treatment or to seek help?
I was full of depression, fear, and also having bad mood swings with anger, stress, all these together, and which felt that I was about to commit suicide. So that's why I thought I needed help. I really needed help, and that's why I came to see you.
It's really good that you came to seek help. But what brought about all this, Angie?
After when my husband passed away, he was such a nice man. He was everything he stand for me, and it so happened that I was so lost without him. Suddenly he disappeared, he died. So with my 3 children, so it gave me at that time that I should be independent myself, which I cannot be independent. And that time there's nobody to seek help, where I have to help myself and I was not brave enough to help myself.
Now you mentioned thinking of ending your life.
Yes.
What kind of feeling did you have? What were you thinking at that time?
At that time, I did not know what to do. And the only thing I felt that came to me that this is the end. I don't know where to go. I'm lost. I should end myself. But I felt, now I feel that it's really selfish for doing that.
I'm really glad you came and saw us, because you're so much better now, I believe.
Yes,
and
very much.
What are your plans for the future?
For the future, I actually, if I like how they are promoting me now, to tell everybody that, to the world, especially to everyone who sees on the TV. It is mine is like a role play example. So there are so many people out there who seeking help, but they don't know how to get the help from. So I hope I'm one of them to show them that, like how I came for this help, and I now feel so much better. Back to society, I can face everything with courage, and be so strong because of you, Professor. So I need everyone who needs help come to you as well to seek all this help. And
thank you very much, and I hope to see you again soon.
Okay, thank you, sir.
Hi. Just now we managed to actually get the opportunity to see how a session happens between a therapist and his patient. We're talking to none other than Associate Professor Dr. Stephen Jambunathan. He specializes in, of course, mental illnesses, something that a lot of Malaysians, a lot of us experience either personally, within ourselves or with people around us on a daily basis, but it's not talked about that much. So my intention is to break that stigma during this interview. Doctor, thank you so much again for being with us, and tell us a little bit more about depression. As you said just now, it's the most prevalent of all mental illnesses, and sometimes people have it and they don't even realize. And to me, that just now was more like a person talking about a problem that they had. It didn't necessarily look like a depressive person. Tell us a little bit more about this.
Yeah, firstly, please call me Stephen.
Okay, I'll call you Stephen, thank you.
Now, depression and anxiety have a very close overlap, and very often one can't differentiate one from the other. Now, it's common, it's very often felt with, firstly, being anxious, nervous, feeling sad, not wanting to mix with people, feeling more withdrawn, losing interest in things to do, appetite changes, weight changes. Your system just closes down.
But isn't this normal human behavior? We go up and down. Sometimes we don't have the mood to go out and play. So my question is, how do you know that someone's depressed? Because sometimes we have mood swings. Is that a depression? How does someone gauge? It's a very fine line. Huh?
Well, across the board, for all psychological problems or psychiatric problems, which are the same, one would look for dysfunction in 3 areas. Interpersonal, personal, and functional. So you either don't feel very good about yourself, or you don't feel very comfortable with others or others with you, and there's dysfunction. You don't function as you normally would. And these 3 main parameters would suggest that you do have a problem of the mind.
Okay.
And that's where you want to decide whether it's psychotherapy, or whether it's psychotherapy with medication, or whether it's any other form of intervention.
And how widespread is this? I mean, like, how normal is it to feel depressed? Does everyone feel it at some point in their life? Or it's an illness? Some people have it and some don't.
Well, everybody feels depressed once in a while, but the illness itself, major depressive disorder, can occur as high as 10 to 15%, and some statistics even say 20%, meaning 1 in 5 people will need psychiatric help for depression sometime down their life.
Interesting. Yeah. And of course it can be triggered by lots of life incidences, like what happened with Angie just now. Okay, now going on to other mental disorders that we've discussed. When we left you off at the break just now, we talked about schizophrenia. The movies have portrayed it in a certain way. What does a schizophrenic really go through, doctor? I'm sure you've seen so many of them. What are these voices like? Are they real audio voices that they hear in their head and things that they see? Is it solid things that they see? What is it like in the mind of a schizophrenic?
I can only say what I know.
Okay.
I hope I never experience it.
Right.
Now, what happens is that for whatever reason, be it biological, be it psychological, be it environmental, the dopamine in your brain gets overactive in certain parts.
Okay.
And the brain starts sending messages to itself without an external stimuli.
Okay.
So a person with schizophrenia could very often would actually hear voices. And you turn and you look, like, I thought someone called me. Who's repeating what I say?
Seriously, they really hear someone.
And why are you looking at me? Can you read my mind?
Why are they saying that? Is it
Why
because
have you just crossed your hands? Are you trying to tell me something?
overanalyzing everything?
Yeah, it comes under the broad category of hallucinations and delusions.
Fascinating.
Very scary, but very real.
Wow. Okay. So I guess what's portrayed in the movies is quite true. Then, tell us about, run us through about other illnesses that you've had to deal with as a person working in this mental health industry.
Well, some of the other common disorders are, like I mentioned, apart from depression, the anxiety disorders, which is actually much more common.
And ADD.
ADD among the children, something very, very underdiagnosed. Very often children are labeled as overactive, or
hyperactive and all that kind of thing.
Yeah.
Okay,
Naughty.
we need to take a short commercial break, and when we come back, we need to address this issue about ADD in children. Like Dr. Stephen just said, probably people don't understand it well enough. So stay tuned, and we'll discuss that right after this break. Okay, when I left you off just now, we were talking about attention deficit disorder. Sometimes children who have this disorder get mistaken for just being naughty or hyperactive. We've just left the cottage, and we're going to sit in this garden, which is a setting that doctor sometimes chooses to talk to his patients at because it's more relaxing. I love this place. It's really conducive to help people let go of their problems a little bit more easier. So now, doctor, back to ADD.
Well,
what is the confusion?
Now, many parents bring their child to me saying, "Doctor, my son is naughty. My daughter is naughty. They just don't want to go to school.
Yeah.
Some of them are doing drugs, and or my children are stupid."
Oh.
And
gosh, that's not a nice thing to say about children.
And what they don't realize is these kids have a learning problem where they just can't focus.
Right.
At one time, it was known as attention deficit hyperactivity disorder.
Right.
And now we've taken out the H. Because you might just have ADD.
Right.
You might be the girl sitting right in front of class, sleeping.
Right.
And it's ADD without H.
Right.
So with the right parenting, and very often with the use of medication, their focus improves.
Right.
And I got a girl from 0 to hero. She's got straight A's in the UPSR after treatment of just 6 months.
Right. So basically, even ADD, you do attribute it to something, to chemical imbalance in the brain. It's not something that they can necessarily control, like stop behaving like that and they can just stop. Sometimes if it really is chemical imbalances or hormonal imbalances in the brain, it needs medication.
Yes. Most of the time, it is a chemical imbalance, but parenting does make it worse.
Yeah, the wrong kind
the wrong parenting does make it
But
worse.
parents are wrongly informed. So if they are educated, then maybe if parents know that these are the signs and symptoms, talking about signs and symptoms, why don't we touch on, we'll do a rapid fire since we have so many things we want to talk about. Bipolar, shoot.
Okay, bipolar. North pole, the middle, and the south pole.
Yeah.
Now we spoke about depression.
Right.
But some people with the same problems, with the same stress, may go high. They might sleep less, need less sleep, get overactive, get hyperactive, get really, really fast, and become so functional that they become dysfunctional.
After they become very functional.
Yeah.
So it's
and that's hypomania leading to mania, when they don't sleep at all, they don't look after themselves, they may even forget rules, break rules, spend too much of money, and dig themselves a hole so deep they can't get out of.
Gosh. Right, okay. And so basically bipolar means extremes, lah? Do these people have a middle ground at all? Sometimes?
With treatment, yes.
Okay, yeah. All right. Next up, OCD. I think a lot of people have this. I probably have a little bit of it as well. Can you explain?
Me too.
Okay.
Well, OCD is another chemical imbalance,
okay,
wherein people tend to repeat what they do.
Okay.
Washing hands, checking doors and locks, even just sitting and thinking about things, ruminating. Or
morbid thoughts?
Morbid thoughts would be something like later when depression sets in,
right,
because of frustration, exhaustion, bathing
okay,
for 10 hours a day and still not being happy and not being able to touch things because of extreme fear of, unrealistic extreme fear of germs.
Right, right.
One would tend to get a bit depressed. And
so if dopamine is the cause, I mean, imbalance of dopamine in the brain is the cause of schizophrenia, then is there also a chemical imbalance that leads to something like OCD? I mean, it's not that bad. I mean, you can't really compare, but OCD is probably not as bad as schizophrenia, but is OCD also caused by chemical imbalance, or it's just a behavioral trait?
Two things here. One is, yes, OCD, like depression, like anxiety, is very strongly linked to serotonin.
Okay.
Number one. Number two, although people don't realize that although schizophrenia can be very debilitating, OCD can be one of the most painful, long drawn and difficult to treat conditions.
If it gets really bad?
Yes.
Right, okay. Now, we've talked about a whole host of mental illnesses and what they seem like, so that all of you out there can pinpoint it and know if you or someone is suffering from it. And again, these changes sometimes can be taken simply as a change of mood during that day, not something which would ring bells or flash flags, so to speak. So there is a fine line between a change of mood on a particular day and something that's steering more towards mental illness. So I would think, am I right? Correct me if I'm wrong. If these changes are so drastic and so prolonged for a very long period of time, and of course as loved ones you would know if these changes are too drastic and lasting for too long, that's when, you know, it's time to actually intervene.
Exactly. But I would like to take it a step further. Don't wait for so long.
Right.
The moment one sees a slight change or a slight difference of concern, seek an assessment.
Right.
Psychiatrists are just like any doctor. There are also psychologists available. And once you see them, once you see a psychiatrist, you don't feel as scared anymore.
Right. And talking about seeing a doctor, like when you have a flu, you see a doctor. And this culture is not prevalent in Malaysia yet, but I sincerely hope, and I'm sure you do as well, that people get rid of the stigma and see a psychiatrist when they know that something is not right. Just like how you'd see a doctor when you have flu. Talking about therapies available, maybe some people are scared that the moment they say psychiatrists are going to be put on Prozac or, you know, medications, and some people want to avoid that. You know, you can't stand the flu, but you can live with the mental illness, they say. So how would you want to erase that stigma, doctor?
Well, I think now with modern psychiatry, most psychiatrists lean towards therapy first.
Right.
Now let's try and talk it out. Let's try and solve the problem. Let's try and get the family involved.
Right.
But if it's too challenging, then we would say, why not try modern medication?
Right.
Why use one hand and suffer for a long time, and you can use two hands?
Right.
Therapy and medicines.
Okay.
And get better faster.
I think what people need to realize is the reality of the situation is something is wrong. Something is wrong. So it's up to you now to decide whether you want to get over the stigma and see your family member healthy quickly. And stigma is only a huge barrier between the illness and getting better. You know, so I really sincerely hope a lot of people will come forward and the culture in Malaysia starts changing. There are many ways to solve it. Art therapy, you know, therapy by painting, music, all these kinds of techniques are now available in Malaysia. Could you explain a little bit more about what you've done in this field, Doctor?
Yes, I ran a couple of workshops on art therapy for the public a couple of years ago, and art therapy itself is very, very useful for children because children sometimes can't speak out their problems. Art is very often a way of bridging that gap. They draw something, they talk about it, then they talk about why, how, and the story comes out.
Right.
And even sometimes adults need it too.
And looking at those paintings, you kind of decipher what the problem is.
Yes, with their help,
Okay, what about music and other methods?
All in the same, music therapy, sand therapy.
You do all this?
Yes.
So that's
not me,
fantastic.
Not me per se, but there are people who specialize in that.
Right. Interesting. Okay, we've come to the end of the interview, but nevertheless, it's been enriching and truly inspiring talking to you. I hope more people will come forward after listening to this interview and you know, coming forward with their problems and getting rid of the stigma that surrounds mental illnesses. It's been a pleasure talking to you, Doctor. Thank you so much for this opportunity. That's all from me, Lakshmi Baker, in this episode of In Person. Stay tuned next week when we will be interviewing another fantastic personality. So I'll see you then. Bye.